Implant reconstruction is the most common technique in breast reconstruction. The reasons are multiple. On the surgery side, it's a fairly straightforward operation to place an implant into a breast pocket in order to restore the shape and symmetry and contour of the breast and to match it to the other side. A patient has very little recovery, relatively speaking. As compared to tissue reconstructive options, the time that it takes to perform the surgery, the time that the patient has to be under anesthesia, the time that the patient has to remain in a hospital for the initial recovery, and then the total recovery time to get her back to her normal daily activities is a lot shorter than if the patient underwent tissue reconstruction. So for those several advantages, many patients elect to have implant reconstruction. And implants are fantastic. They're FDA approved. The silicone that we use today is FDA approved, meaning that it is considered to be a safe device by the FDA. Now, of course, there's a very delicate artistry that's involved in order to create the natural contour and symmetry, and that is a function of the surgeon's experience, skill level, and artistic ability in performing the operation. For my patients, when I'm considering an implant reconstruction, typically a patient will opt for an implant reconstruction if she doesn't have enough tissue to make tissue reconstruction a feasible option. In other words, she tends to be quite slim and trim and doesn't have really much additional fat in the abdominal region or the love handle region to make a deep flap or a love handle flap a viable option. So patients who select implants tend to be on the thinner side. Another appropriate reason for a patient to select an implant for reconstruction is if she has not had or does not need to have radiation treatment to treat her cancer. Now, the decision for whether or not a patient needs radiation really comes from the oncologist. So there's a surgical oncologist and a radiation oncologist who make that decision together. And it's based on the final pathology of the tissue that's being removed. So for example, if a patient has a mastectomy to remove a breast cancer, and if that breast cancer on the initial biopsy is seen to be invasive or have some invasiveness, then a patient would need to have a sentinel lymph node biopsy. That involves removing a lymph node, a single lymph node from the armpit region in order to test it to see if there's any cancer cells that have migrated from the breast cancer in the breast to the lymph node. If there is evidence of a breast cancer cell or cells in that sentinel lymph node, then she may need, I say may because the decision really rests with the oncologist, she may need to undergo radiation treatment in order to lower her chance of cancer spread or metastases or further recurrence of her breast cancer down the road. And so that decision for needing radiation doesn't come immediately. It's usually a decision that's made after the first surgery, after the mastectomy and the sentinel lymph node biopsy, so that we can get some tissue, the pathologist can examine it, and then make that determination, yes, there is some spread to the lymph node, and therefore we should consider radiation treatment. Now, why is radiation an important consideration in the decision for reconstruction? Well, because the long and short of it is that radiation and implant reconstruction don't really mix well together. Radiation causes tissues of the breast to respond by laying down a lot of scar tissue. And as you probably know, if you have a scar on your body, you'll probably notice that the scar has some thickness to it, has some texture to it. It feels kind of firm. And that's because the body's way of healing itself is to form scar tissue, which is made up of collagen. Collagen is the protein that the tissues make in order to lay down scar. Now, why is that important in the setting of radiation? It's because radiation causes the body to produce more scar tissue. And when there is scar tissue around an implant, then there's a higher chance that a process called capsular contracture can occur. Capsular contracture refers to an abnormal scar production process. Radiation accelerates the amount of scar production. Think of radiation as controlled injury to tissues. What the radiation is trying to do is injure the cancer cells because cancer cells are more sensitive to the radiation. That's why radiation is very effective to treat breast cancer. But it's not specific for those cancer cells. So it also affects the surrounding breast skin and rib cage and muscle tissue in that vicinity where radiation is being delivered. So the resultant body and tissue's reaction to the radiation injury is to form scar tissue. That scar tissue is firm, just like a scar from prior surgery. It's firm and it's hard and it can contract. That's just the normal physiology of scar tissue. Now, why is this? So going back to my statement that radiation and implants don't really mix well together, capsular contracture, again, is an abnormal scar formation process. And the process can take place over the course of months or years. So it could be 6 months, it could be 6 years before capsular contracture really manifests itself. And what are the symptoms of capsular contracture? Well, if a patient has an implant in place, then, and if she feels a progressive tightening of the tissue around her breast implant such that the implant starts to move out of place, it might start shifting upwards, it might start shifting to the side, and it can cause a significant asymmetry to result. And your clothes don't feel right, they don't quite fit well, and also it can lead to a lot of pressure that's uncomfortable on the chest from that tightening process of scar. So capsular contracture happens really only with implants. It doesn't happen with tissue reconstruction. If I rebuild the breast with your own tissue, then there's no chance of having this capsular contracture occur at all. And in fact, I use tissue reconstructive techniques to treat capsular contracture. It completely reverses that tightening. So if a patient has had radiation treatment, then she may not be a good candidate for implant reconstruction as a result. But let's take the scenario of a patient who's a good candidate for implant reconstruction. She tends to be quite thin. She doesn't have a significant amount of fatty tissue in the abdominal or the love handle region to make a deep flap or a love handle flap viable options. And she doesn't need radiation treatment, or at least she has an early stage breast cancer that can be treated solely with surgery, and she doesn't need radiation. So that risk of capsular contracture is very low. And perhaps a patient who has a very busy lifestyle, she may have children. In fact, I saw a patient just a week ago exactly fitting this kind of scenario where she had 3 children, very busy, in her 30s. Sadly, she had breast cancer pop up at such an early age, and she's very slim and trim through the waistline and the love handle region. So she was a perfect candidate for having an implant for reconstruction. How I approached it with this particular patient, and which is a common way I approach it, is a 2-stage operation where in the first stage at the time of the mastectomy, for this particular patient she wanted a bilateral mastectomy, double mastectomy. So I work closely with the breast surgeon in order to treat that patient in that first stage where the breast surgeon removes the breast tissue, does the double mastectomy. Then I come into the operating room and I will place a temporary implant called the tissue expander. I encourage you to see my segment on the tissue expander reconstruction. I go into much more detail about it. But suffice to say that a tissue expander is a temporary implant that I place into the breast pocket underneath the chest muscle, and it acts as a temporary spacer. It holds the shape of the breast until the patient has completed her cancer treatment. So in this particular situation, this patient I saw, she had invasive cancer. There's a chance that it involves her sentinel lymph node, or it has spread to the lymph node region. We won't know the answer of that spread until after the mastectomy and until the sentinel lymph node pathology has come back to tell us yes, it has spread, or no, it has not. And that would determine whether we can proceed with an implant or not. But my early sense is that we can proceed with implants because, again, she's quite thin, and also she wants to get back to her normal routine as quickly as possible. I spoke to her about the second stage of reconstruction, after the tissue expander phase where she's treated with the mastectomy and the tissue expanders. Then she recovers. We figure out whether she needs radiation. We figure out how much more cancer treatment she needs. Then after typically about 3 to 6 months, we can move to the second stage of surgery, which is to remove the tissue expanders and place the permanent implants. So let me show you what sort of implant that I like to use. It's called a teardrop implant. It's a silicone gel filled filled implant, and here's what it looks like from the front view. And from the side view, it has the shape of a breast. Let me give you a little close-up on that. You can see that, well, first of all, when I manipulate it in my hands and I sort of squeeze it, you can see it's very flexible. It's kind of squishy to the touch. It's very soft. Feel like a water bag or a water balloon. A saline implant would feel like a water balloon. It's more firm. The water is more just liquidy, whereas this has a very soft feeling. The only reason we use silicone implants is for the natural feel. That's the only reason we use silicone, because it has the most natural feel possible, whereas a saline or water-filled implant does not feel natural at all. And actually, in a situation of a mastectomy, you can often see rippling, little ripples or irregularities across the surface of the breast with a saline-filled implant. That's why silicone implants are so important for breast reconstruction in particular. But sort of going back to the close-up here, from the side you can see this is the back side of the implant, and this is the front side. You can see that the front side has the shape of a breast, where it's a little bit flatter up top, and then as you move down the breast implant, it has more volume and fullness and shape to mimic the shape of the breast as if you were looking at it from the side. The front here has this little stripe to orient the surgeon to where the bottom of the implant is placed, so to make sure that the implant is not placed in the wrong orientation. And you can kind of get a sense, it looks like a rough surface here. This rough texturing of the surface of the implant is to prevent rotation or migration of the implant. So the tissues actually hold on to the implant much better with this textured surface. And that's very important to prevent rotation. You can imagine that a rotated implant would make the breast shape look very unusual and not normal. Now, this is called a teardrop implant or a gummy bear implant. The technical name for the silicone is cohesive gel. Cohesive gel just refers to the fact that the silicone gel stays as one solid mass. So if there's a break in the implant, if there's a small tear in the implant, then the silicone doesn't leak out into the tissues. And that was actually a big problem prior to 1992, which was the reason why the FDA banned the old silicone implants after 1992. And then there was a 15-year hiatus, during which time we could not place any silicone implants in this country. It was completely banned by the FDA. But during that 15-year period, the implant manufacturers did a lot of research and development, spent many, many millions of dollars to try to come up with a cohesive gel that retains the same tactile qualities of silicone. It's still soft, it's still gel-like, and still very natural. But if there's a break in the implant shell, then the silicone stays right where it is, and it doesn't leak out into the tissues. So for all practical purposes, we can safely assume, at least the FDA says that we can, that even if there's a break in the implant, we don't have to stress about it. We don't have to worry about leakage of silicone. One question I get from patients is, do I have to undergo any kind of MRI scanning or testing to see if there's any leakage of silicone? And the answer really is no. Now, the FDA has a mandate that has been in place since the days of the old silicone prior to 1992, where they recommended that a woman undergo an MRI scan of the breast area 3 years after placement of the implants, and then every 2 years, in order to monitor for occult or hidden sort of silicone leakage. And that mandate was important back then, because we would want to know if there was any silicone leakage in an old implant, whereas for a brand new implant, the cohesive gel or gummy bear implant, that is not a concern, because again, the silicone gel stays as one unit. Now, if you were my family member, my sister, my aunt, my mother, I would fully support the use of silicone implants if my family member was in a situation of needing to have a mastectomy to treat breast cancer, and she was considering her options. So for me personally and for my patients, I find that silicone implants manufactured in this country, and there are 3 implant manufacturers, Mentor, Naturel, and Sientra, that are safe to use and they're FDA approved for the use in breast reconstruction.